Okay, let's just start. See them later. So we were discussing about all diagnosis and all history and examination, where we were going very fast because it's a huge slide. The other reason is you already know how to take history and examination. So this is just a kind of revision. That's why we are going a little fast. So we had all diagnosis and then clinical examinations, 4 types. Then we do the complete examination, having case history, clinical examination, diagnostic aids, the failures in diagnostic process, diagnostic process, the uncertainties in the diagnostic process by the patient and the doctors both. Then we went to the steps of case history. I hope it's recording. Yes, it's recording. Okay, perfect. So there was personal data, chief complaint, history of presenting illness, past medical history, past surgical history, past dental history, family history, social history, personal history. Personal data was totally administrative and your personal use for the records. And then this was objective and subjective area of the case history. And then we had some skill area, medical examination, oral, extra-oral, intra-oral, and then systemic examination included the review of the system. And then we had investigation, which were general and specific to the oral cavity and head neck region, intra-oral, extra-oral region, and then general investigations. And then imaging studies, radiological examination, and some advanced imaging techniques. Finally, with all of this, we went to differential diagnosis. Excuse me. We made a list of diagnoses known as differential diagnosis, and on the basis of investigation and imaging studies, we ruled out the provisional diagnosis and made a treatment plan suitable for the patient. Then we went through the personal data, including patient name, gender, age, marital status, occupation, and interest. What was the purpose and use of these personal data? Why we take it? And then we went to chief complaint, how to write it, chronological order, patient's own words, what were the chief complaints in the oral cavity related to head and neck and all region. And then before going to history of presenting illness, we should know what are the symptoms, what are the signs. Symptoms are by the P and the patient, subjective information by the patient. Signs are the findings by the examiner. We had 4 tools for signs taking, which were inspection, auscultation, palpation, superficial and deep, and then percussion. And then I hope you all know how to take this examination, physical examination of different parts of the region of the body. For example, how to take a thyroid examination, and then lymph nodes of the deep cervical neck, and then there was some abdominal examination and hernias examination. And then you need to learn this before you graduate, or maybe you have learned it and then you have to revise it, and then the exam you have to reproduce your skills. And then we go to a history of presenting illness. Then we need to ask the questions which were shortlisted in chief complaints. For example, we have taken out 2 or 3 chief complaints which is necessary to solve first at this moment, at the present time. So we need to ask the question related to those chief complaints, those presenting illnesses, and these are some questions. And then if there is pain, we have to know how to take history of patient with pain and what is pain history. And for that we had a mnemonic, Socrates. And then how to remember is by this face, his name is Socrates. And then these are the questions. And then we had this beautiful diagram, or you should say a table, where we know the mnemonic, the heading, what is the related questions to be asked, and what will be the common answers. For example, onset, how to ask a question about onset. When and how did the pain start? So the answer will be gradually, or it started 6 months ago or 2 years ago. I had pain, but it went on and off, and this and that. So these are the questions. Okay, so now I have two things to share with you guys. Number one is why sometimes a lot of students are brilliant and they know the Socrates, what is defined, right? How it is the S is site and O is on site, but they do not know, or they have not practiced how to Ask question to know the answer of the site, and how to ask questions to know about the timing and what is the difference between timing and onset and duration and these things. So these questions are important to practice and make this part of practice, right? And the second thing I want you to know is this is an important part. Second part is that this important part, maybe the patient has already told in the chief complaint. For example, doctor, I had pain 3 months ago. It started 3 months ago. Initially it was a very sharp pain. So you got onset and you got corrected. Initially it was sharp pain, and then after 15 minutes of sharp pain, it changed into dull. You see, so you have the character of the pain and then association. Doctor, so when I cannot bear the pain, I take some NSAID and it is relieved, so there we have relieving factor, right? So maybe the patient has already told you, and maybe you already recorded it. But if you are uncertain, you can write, for example, in history of presenting illness, you have some pain, you have written some pain, right? About some pain, right? So on this, for example, this line is about site. You can write S for your configuration. This is how I used to do it. Okay, for example, in history of presenting illness, because I had a lot of patients. For example, you have a lot of patients, and history of presenting, his chief complaint, history of presenting illness, and then under that you have written a lot, and then some of them related to pain, and this is related to onset of pain. So I write O, and then is related to onset of pain. Okay, so history of presenting illness, I had a lot of things here, and this thing is related to pain, and this is to the timing of the pain, so I write T. So this and this is severity, and this is association. So when you have, so some of the characters of the pain, some of the headings you already covered, and then when there is pain history, then you can ask about the remaining to save your time and be more efficient and professional. Otherwise the patient can think, oh, I already told him the timing of the pain and association and this and that. Why is asking me again from 0 to 10? How the severe is the pain? Why is asking? He's already asked. Yeah, I told you it's very severe, right? Severe means 8, 9, 10, right? So why you need to ask me like this? So this comes out of the practice. So the two things were, number one, you should know what are the headings and how to ask the relevant question to get the right answer, what you need to be a part of your history. And the second, that comes from practice. And the second thing is, some of the questions will be answered here, so you can ask the remaining of the Socrates mnemonic of the pain history to save your time, patient's time, and everyone's time. Okay, so these you need to practice. Okay, so now some essential principles, which include self-administered pre-printed forms filled by the patient and direct interview with the patient by the clinician. So you can make some of the handouts. For example, they are waiting in the waiting area and you are with another patient, and the patients are waiting in the waiting room. You can ask your assistant to hand out some pre-printed forms or handouts, which they fill, which can be helpful in the history taking. And then when they come in with the history taking page or form, and then those questions who don't know they don't know how to answer them, you can ask them again to fill. This will save time, and these are some essential principles which you can use. You can use both. For example, a patient come to my clinic, he or she is sitting in the waiting area. While he or she is wasting her time, we can make this time efficient. My assistant will hand out a pre-printed form on any survey or anything, which basically helps in the diagnosis and history taking or examination of the patient. And then my assistant says, okay, you read this pamphlet or handout or form and answer as many questions as you can, and if you are uncertain, you can leave it. This is a simple direction given outside, which saves the time, and you can use. And then when the patient come in, you can ask the related questions, or if you think the answer is important or is not correct, then you can ask the question again to save time. These are some principles you need to follow to improve your technique. Okay, so now we go to the Past medical history. It depends on the serial illness, previous heart attacks, bleeding disorders, fits or faints previously, or you have hospitalized for surgery or anything else, have some seizures or like epilepsy, anything, any allergies that should be considered for the patient so that before giving the treatment. Then medication in the last 6 months. What are the especially the antibiotics used in the last 6 months? Do not repeat it. Give an alternative, but do not repeat the antibiotics used in the last 6 months. Please do not create resistance for our generation, coming generations. And then childhood diseases as rheumatic fever. So this is the difference. This thing is a difference between a clinician and just a chemist. Okay, so childhood disease as such as rheumatic fever, as you know, it's related to the oral cavity, and then comorbidities like hyperlipidemia, diabetes, obesity, and any smoking habits, like, which cause comorbidities, and anything, right? Like X-linked diseases or genetic disorders here. So this comes in past medical history and surgical history if it's related to surgery. Then what is the significance? It may be related to the diagnosis. Precautionary measures are sometimes indicated. Okay, this guy had a metal rod in his arm, MRI contraindicated. Yeah, MRI CI. Yeah, you write it. Pre-medication or controlling before dental treatment. For example, this guy is getting a blood thinner, platelet dissolving medicine. Yeah, and then you are giving some other medicine which is contraindicated with his previous medication. That's why you need to know the previous medication or pre-medication. Yeah, for medical consultation if needed, and dental treatment might affect the patient's systemic health. So that is the significance of the past medical history. You need to know because this treatment can affect other treatments and vice versa. So why to take a past medical history again? Because many medical problems or drugs can affect or influence the provision of medical care, such as heart diseases or any MI. We cannot give oral medicine or any antibiotics, whereas other conditions are already there. We need to choose our medication. In the case of heart diseases, allergies like penicillin allergies, need to non need avoid penicillins antibiotics. And then diabetes and bleeding disorders, we need to take care of these diseases. That's why past medical history is important, and past medical history includes these questions: comorbidity, allergy, pre-medication, bleeding disorders or genetic disorders, and comorbidity, these two, right? Basic medical questionnaires. These are the basic medical questionnaires asked in the history of presenting illness or past medical history. We also had a questionnaire to ask in the chief complaint. We also had signs and symptoms from chief complaint. We have a questionnaire, these questions to get some idea of the questions to be asked in the history of presenting illness, because we need to know more about the presenting illness. So it will be focused on the chief complaint or the presenting illness of the patient. And same as we had, if he has pain, then we had a pain history questionnaire and questions to ask about the pain. And then we have past medical history. Now we have questionnaire to know about the past, which includes does he have anemia or allergies, bleeding tendencies, cardiorespiratory complaints, drug treatment, endocrine disorders, fits or faints previously, and then GI complaints, hospital admission, attendance, or any surgeries, HIV or AIDS. Very important to ask in comorbidities. So I usually ask in the comorbidity, but I used to ask in the comorbs. Comorbidity are the diseases which are occurring at the same time the patient came with a new complaint or the existing complaint. These are to check for anemia and jaundice. Number one, HIV, AIDS, hypertension, or hyperlipidemia. You make your own list, right? And then obesity, you check the weight, height and weight, yeah, comorbidities. And then you can ask for other these or Hep B and C, very important, Hep B and C, yeah. These are the things, these are the comorbidities you need to know on your fingertips, because these should be given special attention. HIV and AIDS AIDS. A patient has an HIV and AIDS. You should not give him special attention. You ignore this, and he's on the surgery table, and the surgeon is is operating on that patient, and then he cuts him. The blood is mixed, and then later on we knew that the surgeon had HIV. So okay, that's a very huge mistake, professional criminal mistake. Okay, so jaundice or liver disease, and then hep B and C, and jaundice and renal disease, right? And these are the questions, medical warning cards. This guy has epilepsy, or he has seizure attacks, huh? The hemophilic or long-term corticosteroid therapy. This guy is immunodeficient or allergic to penicillin. These are the question, basic medical questionnaire. Some are as same as the history of presenting illness, but why they are different? Because that in that category we are asking about the allergies or the pre-medications or these things related to the chief complaint. But these basic medical questionnaire, which is done in the past medical history, are the generalized questions. That's why they are different. And then medication history, which drugs are you using, how many doses you're using, how many times you're taking, and if it's working or not. These are all the drug reactions, and what the drug you are going to give, what the treatment plan you are going to give. Maybe they have a reaction, drug interaction, or adverse reaction. That's why you need to know the pre-medication or medication history of the patient. We usually ignore these things. Okay. Now we go to the past dental history, the general dental history related to this oral medicine. Yeah, that is frequency of visiting dentist and purpose of visit. What is your, how many times you visit, purpose of your visit, restorative dental procedure, past caries experience. What is caries experience? Caries, dental caries, right? Dental caries. So any dental caries, a lot of students have, a lot of patients have assessment. We need to assess the past dental caries experience and restorative dental procedures done, RCT is done, or any cap is given, and then local anesthesia. If you have any problem in anesthesia previously, or if I give you anesthesia right now, you need to take a consent. Past oral surgical procedures, bleeding and healing processes and tendencies, previous orthodontic treatment, and then prostheses given, artificial teeth, periodontal disease. You know the 4 tissues of the periodontium, right? Odontarium. They were cementum, heart tissue, yeah, remember, right? And ligament. And then previous periodontal treatment and history of denture wearing. Denture, what is denture? These are the artificial set of teeth and cause of lot of teeth. You know why you need to know this? If the person is on surgical bed. Whenever I was in my department of general surgery, whenever we had an operation, right? Before this, the anesthesiologist removed the denture, because that denture can, if there are 1 or 2 teeth, they can go inside. The patient is anesthetized, he doesn't know, he or she doesn't know. So that's why we need to know denture wearing history, not only in the dental history but also overall. Important. Have artificial or loss of teeth. Okay, next we go to the family or social history. Again, hemophilia, diabetes running in the family, and genetic disease, and then hypertension, allergies, and whatever the social history, socio-economic background or marital status the patient has. We need, if we have previously skipped it, we can write it here, because these steps help us to remember what is the information needed to ask. And if you have previously recorded this information, no need to record again. And if you don't have any finding, or you fail to ask, just write none, or none recorded, or NAD, nothing abnormal recorded, or NAD, nothing abnormal detected. Yeah, NAD, nothing abnormal detected, or no abnormality detected. Yeah, you can write none or NAD. So now personal habits are important, because as you know, they smoke. Some patients smoke. It can cause pigmentation of teeth, and some patients use illicit drugs and they do not take care of teeth. They avoid toothbrushing and flossing. that is related to oral hygiene habits, and that's why it is related to personal history, personal habits. And some patients have habits of nail biting, lip biting, thumb sucking, related to oral cavity. Parafunctional habits like bruxism, clenching and tapping, seen in the children. And then smoking habits, these are all related in the personal history. Okay, now we go to the next session, which is examination. It depends on your skills. For oral cavity specifically, we have two types of examination: extraoral and intraoral, right? So extraoral examination for routine clinical practice, this can be usually limited to a visual appraisal, like outer, we have a patient in front of us facing towards you, his eyes or her eyes are towards you, and you are looking for swelling. Extraorally, you are appreciating the structure and anything, like you're finding for abnormal findings like swellings, asymmetry, cleft palate, patient's color, anemia, right? Jaundice, okay, pale looking, yeah. A more detailed examination can be carried out if indicated by the patient symptom. For example, you have a swelling on patient's lower jaw. Now, a detailed examination is there. Now you need to examine the swelling. You need to touch, see the texture outside is rough or is smooth, and is it movable or is attached to the underlying surface. Yeah, if it's hard, if it's cystic, if it's contain fluids, these are. And then light test, you take a torch and see if it has fluid or not. If you find a normal finding extraorally in extraoral examination, EO extraoral examination, then you go for a more detailed examination for that part of abnormality. And then the other part is intraoral examination, which contains oral hygienes and then soft tissues. But a soft tissue, you need to see the oral mucosa. If there are some lesions, there are some you can say we have some dots. Those are known as infection. And then there are follow, excuse me. So periodontal conditions, sometimes there are some infections related to oral area, those oral, there are some lesions. So soft tissue, internal oral cavity, entire oral mucosa, you need to carefully inspect. Any ulcer more than 3 weeks duration requires further investigation because it's not healing. Some aphthous ulcer are formed. Sometimes an idiopathic ulcers known as aphthous ulcers are found in our body, right? In our oral cavity. And those aphthous ulcers should heal in 1 or 2 weeks, but they are not going. They are more than 3 weeks duration. Then they require further investigation. And then some periodontal conditions should be assessed rapidly. Pockets of pus, you're talking about pockets of pus more than 5 millimeter indicate the need of more thorough assessment. Periodontal condition, they are talking about intraoral, we are inside the oral cavity. So oral hygiene, soft tissue, oral mucosa, ulcers, periodontal conditions like pus pockets. Chart the teeth, you can see which teeth are present and absent, and then you need to chart based on your Palmer or universal notation system, which we have studied previously. And then examine each tooth in turn for caries and examine the integrity of any distortion present if there are done some dental procedure. And you should see for the caries with the mirror. Yeah. And then occlusion, this should involve not only getting the patient close together and examining the relationship between the arches, upper arch and lower arch of the jaw, but also looking at the path of closure for any obvious prematurity and displacement of the teeth. Check for the evidence of tooth wear. Occlusion, at occlusion, we see the grinding surfaces, we see the caries, we see the obvious prematurity or displacement or tooth wear and tear is an occlusal surface. This is a short version of bedside oral exam. I have found this, and you can see here is the category: swelling, and then swallowing. The reflex, swallow. If the patient swallows the food or drink normally, or if there's pain or denophagia, right? Or dinophagia, there's pain with swallowing or unable to swallow, we need to intubate. Absent gag reflex. Okay. And then we have lips. We need to observe the lips, smooth, pink, dry or cracked, and ulcerated or bleeding. And then we have tongue, 3 types: saliva, copious, thick, watery, mucous membrane, pink, moist, red, coated or no ulcers and ulcers, and then gingiva. We have swollen or not, edematous or not, or red or not, or white, hairy leukoplakia. We also need to see hairy leukoplakia here in the tongue. And then teeth, we look at the teeth, clean teeth, no clean, or local debris or plaque or calculus formation, and general debris or decay. And then we look for order, means smell, normal, slightly to moderate for. So on the basis of this, this is a numbering system: 1 for normal, 2 for moderate, and 3 for severe. On the basis of 1, 2, 3, 4, 5, 6, 7, 8 findings, we can give a score. On the basis of score, we need to see, okay, this problem, the overall oral exam, bedside oral exam has this marking, or it's normal, it's moderate, mild, moderate, or severe in nature. So this is very important for you to remember in the case of oral exam. This is bedside exam. And this is also a severity of problem. So this is table number 1. When you are doing taking a history, these are how you proceed. You take history, you progression, history of the problem, the progression of the problem, location. This is another way of taking a history, short history, and then you know the severity of the existing problem or the chief complaint. So how you remember is you just take the history, brief history, how when it progressed, how fast it's progressing, and location where it is a problem, and the intensity, the character, aggravating, alleviating factor, associated symptoms, past medical history, family, social history. So this is a short version of ascertaining severity of a problem, usually done in the emergency department. Because emergency department, we don't have a lot. So this is emergency type of clinical examination. Example. So systemic examination, review of system. So we have, I think we don't have a lot of time here on our side. We have less than like 9 minutes. Okay. So review of system, as you already know, you go for the general, you go for the jaundice, anemia, you look for the cyanosis, peripheral and blue extremities and central blue tongue, right? And then go for the dehydration and lift the skin between the thumb and forefinger, or you can just see the pale for anemia, jaundice, yellowing of the skin. So this will help a general a review of the system or systemic examination. ROS means review of system. We have done the oral examination, intraoral, extraoral, and now we are going all over the other systems which have some association with the current condition. And very important here, if you have not previously noted, weight question related to the weight of the patient has increased in the last 3 months, have decreased in the last 3 months weight, change in the weight in the last, and appetite. So I have made previously when I was in clinical rotation, also in my post graduation, I made a chart by myself which had a lot of questions, and I made basically a handout, a pamphlet. I'll later share you in the group if I still have it. That's very important. That's very easy to remember. And once you practice it, you don't need to go elsewhere. Just stick to them, and then every question will be answered, including comorbidity and anything. So where it is gone. Okay. So cardiovascular, next is cardiovascular system. You need to know about the heart and vessels. You feel the pulse, time the pulse, you time the blood pressure, and listen to the heart sounds if necessary, and murmurs, and palpate the peripheral and radial pulses together to see if there is delay, radial delay or radiofemoral delay. Okay, then we go for the respiratory system. We see the respiratory rate, expansion of lungs on the both equal sides, and if there is wheeze, which indicates infection, fluid, or asthma, and any crackles. And then GI system, you ask the patient to lie supine and relax, and you have to palpate all the nine regions of the stomach, of the abdominal area, starting from this, and then you go to S shape, right? 1, 2, 3, like you palpate, you superficially palpate, and you depalpate. Yeah, so palpation is auscultation, inspection, and percussion is done in GI system. But for GI system, when you are doing, first you inspect, and then you auscultate, and then you palpate and percuss. But you should percuss first, because then you cannot find the readings in GI system. And then the genitourinary system, you ask about, mostly covered by abdominal examination. They usually genitourinary system or review of the examination of GU system is done in the GI system. But if you have skipped it, you can do it, because patients with genitourinary symptoms are more likely to go in the operative urinary retention. You need to ask that. Sometimes patient after dental procedures also can suffer from post-operative urinary retention. Indicated and should not be conducted by the non-medical qualified person. So pelvic and rectal examination per rectal are not required during dental review of the system or systemic examination related to dentistry. Then central nervous system, see the patient is alert, ask the orientation of time, place, and person. Where are you? What's your name? And is it day or night outside? And then you can ask for the cranial nerves. You can examine the cranial nerves, because some of the cranial nerves are important for us, like 5, 7, 9, and 10, as we have read in the anatomy of the oral cavity, the first slide. So cranial nerves examination is important. And then musculoskeletal system, you ask for arthritis and some cervical spine hyperextension, okay, related to the anesthesia, because sometimes you have to perform prolonged dental procedures which requires you to give local anesthesia. So at that time, if the skeletal system or cervical spine have some problems, so you suggest some collar to protect the neck during the dental procedure. That's also important to get musculoskeletal system examination. And then in investigation part, there are general investigation, and then there is specific investigation. General investigation include temperature, pulse, blood pressure, all the vitals, and then urinalysis, and the blood tests like blood full count, biochemistry like arterial blood, and then virology, immunology, bacteriology related to the so of course overall, for example, if a person has a rheumatic disease which has a relation to the oral cavity, so we need some these general investigations to be done. And then blood cultures and biopsy and cytology. And then in the case of specific oral investigations, we have sensibility testing of hot and cold, and then we apply for cold and apply for hot, and see the severity here. First we see the sensibility, over cold and over hot has sensibility or not, and then we see the severity of the sensibility of cold or hot sensations to the teeth. And then there is electric pulp tester. This is the test done specifically for oral cavity. Then test the cavities with a mirror, investigate, and then percuss the mobility of teeth, the palpation, you palpate it, biting onto the gauze or rubber, you see, and the intactability of the teeth, local anesthesia, ask for local anesthesia. If patient has previous complaints with the local anesthesia, then we have to avoid this. And then the radiographs also help in the investigation. And the imaging studies specifically done for different areas of the oral cavity. So radiographic choice for different areas. General, if we are going for general scans of teeth and jaws or retained roots under teeth, we go for DPT. And localization of under teeth, we go for periapicals. Crown of the teeth, we do for between. And then root and periapical areas, periapical radiograph. Sinuses, okay, this is important for the sinuses, because it's related. For example, some patient has reoccurrence of sinusitis, we can do a occipito-mental radiograph. And for temporal joint, we do DPT and MRI. Skull and facial bones, we also go for occipito-mental. So skull and facial bones and sinuses, we go for occipito-mental type. You remember as much as you can.